Hi, this is Dr. Terry Schoenfeld from the UAB Department of Medicine. In this video, I'd like to compare the Revised Cardiac Risk Index, also known as the Lee criteria, with the NSQIP or Gupta criteria for predicting cardiac risk of major non-cardiac surgery. Now, cardiovascular stress testing has been used to try to predict cardiovascular events in patients undergoing non-cardiac surgery, and it had limited predictive ability. So it's recommended that a variety of prediction tools be used to estimate a patient's risk of developing a cardiovascular event following non-cardiac surgery. And the two most commonly used tools are the Revised Cardiac Risk Index, also known as the Lee criteria, and the NSQIP tool, also known as the Gupta criteria. Now, both of these are available in a wonderful tool called Calculate by QXMD that's available for both iPad, iPhone, BlackBerry, and Android. And I recommend you add this tool to your smartphone or iPad. It has lots of other prediction rules in it also that will be useful for clinical care. So let's look at the factors that are predictive of cardiovascular events following non-cardiac surgery. First, for the Lee criteria, these 5 elements were found to be predictive of cardiovascular events: history of ischemic heart disease, history of heart failure, history of cerebral vascular disease, insulin requiring diabetes mellitus, and chronic kidney disease with a creatinine greater than 2. Gupta's tool includes these 5 elements: age, creatinine, American Society of Anesthesiology class, perioperative functional status, and importantly, procedure type. So let's compare these two tools to each other, how they were developed and how valid each one of them are. In the middle column here, I have information about the Revised Cardiac Risk Index, and over here on the right, information about the Gupta tool. So first off, you can look through here and see that the Lee criteria was a prospective cohort study of patients they followed specifically for the purposes of developing this risk prediction tool, whereas the Gupta tool was developed using a database that was designed for improving surgical care across the nation. You can see 4,000 patients were used to develop and validate the tool versus almost 500,000 in the NSQIP tool. Everybody was at least 50 years old in the Lee criteria. The Lee criteria developed in the early 90s compared to the mid to late 2000s for the Gupta tool. I think it's important to spend some time here on the outcomes that these tools predict. So the Lee criteria predicts in-hospital myocardial infarction, pulmonary edema, ventricular fibrillation, cardiac arrest, and complete heart block. Whereas the Gupta criteria were designed to predict myocardial infarction or cardiac arrest through 30 days post-operatively. Now, there's a difference also in how MI was identified. In the Lee criteria, this was CK-based, but it was also done prospectively. So patients, each day they were in the hospital, had CK determinations to look for myocardial infarction. This is important because many post-op MIs are silent and will be missed if you only rely on patient symptoms, which is what was done in the NSQIP database. Only when patients were suspected of having a myocardial infarction was a troponin measured and an EKG done. It's also useful to note, because this is troponin-based, it's a little bit more sensitive than CK-based measurements. Likely, though, the NSQIP database under-identified myocardial infarctions because many of them are silent. The NSQIP tool is surgery-specific, where the Lee criteria are not. And then finally, let's look at the validation of these two tools. The C statistic is a measure of discrimination, meaning will a tool correctly identify if somebody is having a disease or not. It can range from 0.5 to 1. 0.5 is useless. It is basically a coin flip. 1 is perfect discrimination. And in the original study, in the validation cohort, the Lee and colleagues found their C statistic to be about 0.81, which is pretty decent. It's a very moderate or a slightly greater than moderate degree of discrimination. If you look at the Gupta tool, it's a little bit greater discrimination at 0.87 when you looked at all surgeries, and when you looked at just vascular surgery, it's about 0.75. Now, the Revised Cardiac Risk Index has been looked at by other folks. Ford did a meta-analysis in the Annals in 2010 and found the overall C statistic to be about 0.75, which is moderate at best. Gupta also looked at the Revised Cardiac Risk Index in their study and found it to be similar to what Ford found at about 0.75. And if you looked at vascular surgery patients, it wasn't much better than a coin flip at about 0.59. So the highlights here is that more people were used to develop the Gupta tool. It was developed in a broader group of hospitals. It was developed at a later period in time when there's been more advances in cardiac care, anesthesia care, surgical technique. It is very surgery specific and a little bit more valid. So in summary, the NSQIP index has better predictive performance, it is surgery specific, and is more contemporary. But the Revised Cardiac Risk Index has been around for a while, and a lot of physicians feel comfortable using it. It has been used in a variety of different perioperative surgical studies, so there's comfort to using it. I think the bottom line is what's recommended in the up-to-date summary of this is to become familiar with one of these models and to use it regularly. For me, I prefer the NSQIP index just because of the information that's mentioned at the top.